Good morning,
Oh, yeah.
or good afternoon, everybody. Welcome, welcome. Thank you so much for joining us today. I'm just going to give it another minute or so, and then I'll start the introduction, and then we'll get on with the webinar. All right, it's 1 o'clock, so we're going to go ahead and get started. Welcome, everyone, to our EP webinar. We're glad to have you all here today. Thank you for registering for the Emergency Infectious Disease, Novel and High-Risk Infection in the Home and Community-Based Services Population webinar. This presentation is going to be 1 hour. Feel free to put your questions in the chat, and Terry will answer at the end if there's time, or in an email after the session today. Our survey will pop up after the presentation and will also be emailed afterwards. We encourage everyone to take it. If it does not populate for any reason, the link is also in the chat. Slides recording will be also emailed after the presentation today. So you'll see those coming from myself or someone on our HCA team. And unless there's any questions or concerns about any audio or visual issues, we can go ahead and get started. Now, Peter, our Executive Vice President for Clinical and Program Affairs, will introduce our speaker and give you further background on our webinar. Peter?
Thank you. Appreciate it. Terry, if you can move the slide forward. Uh, I'm really happy to welcome everyone. We have a wonderful registration for today's seminar. And so I'm going to be as brief as I can. I want to also welcome you on behalf of our President and CEO, Al Cardillo, who is not able to be here today due to a personal matter with a colleague who's passed away and whose funeral is today. And he regrets not being here, but he's somewhere in Western New York right now. I'm happy to welcome you and also to acknowledge the support of my colleagues here at HCA who have been part of our team's effort in advancing our work in this important area, and that includes Kiernan, who you've just met, and Wendy Parker, who's our VP for Program Services and Development. This is a project that entails 5 webinars, 3 special training sessions, and some other activities, all of which are geared toward addressing emerging infectious disease and novel influenza outbreak in home care settings. We're really so pleased that there's been the kind of interest in this very important topic, and our focus on this initial module is going to be on the identification, etiology, prevalence, and implications for home and community-based service sector folks. So again, thank you for attending today. We have, I guess, 5 total webinars planned, and I don't guess, I know. And you're welcome to attend any of those that you're interested in, but we encourage you to attend the full series because we've constructed this to really build some progressive knowledge and skills for capacity in serving in home care around these critical issues. So thank you again for joining. I have a couple of quick acknowledgments as well. Next slide, please, Terry. Uh, First, our project and our gratitude to Fidel Monroe, and who's senior program manager of long-term care at the Bureau of Healthcare and Community Readiness, the Office of Emergency Preparedness and Response in New York City at the Department of Health and Mental Hygiene. Fidel has been a terrific partner with us in the areas of emergency preparedness and has supported us with this grant through the U.S. Department of Health and Human Services. And we're, really very grateful for her partnership and support and the opportunity to really bring forward such important information to New York City and throughout New York State. We're also pleased to partner with IPRO for this webinar and for the training series that we have as a part of the grant. And I want to give a warm welcome to Sarah Butterfield, who is quietly on the webinar, but I think muted and off camera. Sarah and her team are great partners with the Home Care Association of New York State, and we're really just thrilled to be working with her and her team. And today, a member of IPRO's team, who is going to be going to be presenting today's seminar, is Teresa, Dr. Teresa Lubowski, who is at IPRO, and I believe her title is the lead for patient safety, clinical aim, director of quality improvement and medication safety, and consultant for CMS quality improvement initiatives. A very deep background and strength in the areas of quality improvement, and she is by profession a pharmacist. And has a really strong background in professional pharmacy experience, as well as in academic fields and in her research and work, particularly around the areas of quality improvement and infection. I'm blowing it, Teresa, so I'm going to really transition now to you with no further ado, because we have a tremendously packed seminar and a lot of information to share. So, Terry.
Thank you, Peter. So welcome everyone. And today, these are the learning objectives for our talk today. And we're going to focus on viral respiratory tract infection overview. And we're going to look at viral respiratory tract activity in US and New York State. We're going to look at key facts associated with respiratory tract infection caused by COVID-19, RSV, influenza, and H5N1. And we're going to look at similarities and differences in vaccines, presenting symptoms, and treatment options. So we'll start with a look at the levels of acute respiratory tract infection in the US. And you can see at the top, there's like the key. So very low is that light blue color. Green is low areas of acute respiratory illness. Moderate is the orange. High is the red. Very high is the purple. And the date for this data is actually February 18th, so it's very recent. And when you look at New York State, you can see that we are in the green. And most of the states surrounding us are also green, with the closest orange or moderate being Ohio and New Hampshire. This is the percent of positive tests for the viruses we're going to look at today. So the orange is your COVID, and you can see the orange COVID line actually kind of decreasing. So these are positive tests. You can see this goes from November 2024 up to February 2026. So COVID is kind of along the same lines as it has been for a while now. The blue is the influenza, and you can see two huge peaks in influenza, as you usually see, with December, November. And we're in a peak right now with influenza. And the purple line is the RSV. So RSV, you can see most of it low, low, low. And now it's just like on a little steady increase going up into February of 26. This is a look at hospitalization rates specific to New York. So if you look at the top of the screen, this is a CDC website. And I selected New York, and then it shows you the hospitalizations per 100,000 people. And the graphs represent the three primary viral infections. So COVID-19 is the orange line, and you can see it's pretty much nicely decreasing. The purple line is the RSV, which is increasing a little. And then the influenza are the blue. So you can see the two huge peaks. And now the hospitalization rates continue to decrease. This data was last updated on February the 12th, 2026. All right, so with that as our background, now we'll go into the different viruses, and we'll start with the respiratory syncytial virus. The RSV causes and spreads. So RSV is highly contagious. And this happens by inhaling droplets of the person's cough or sneeze, or by touching contaminated surfaces before touching your own eyes, nose, or mouth. And outbreaks tend to occur in classrooms, community centers.
Yeah, he's not here. He's not a member service.
Oh, I think Kieran, can you, if you're not asking a question, would you please put your microphones on mute? Thank you. and childcare centers. In most cases, people with RSV are contagious for 3 to 8 days after their first exposure. So it's a long amount of days. And someone like infants and people with immune system tend to be contagious or may be contagious for up to 4 weeks. RSV can live for many hours on hard surfaces like tables and not as long on soft surfaces like tissues or hands. RSV is very common among children, and almost all children will have had it by their second birthday. Well, symptoms of RSV are presenting clinical symptoms. In adults age 50 and older, RSV usually results in mild or no symptoms. And symptoms may include the rhinorrhea or the runny nose, pharyngitis, sore throat, cough, headache, fatigue, and fever. And mild illness in adults typically resolves in 1 to 2 weeks. And symptoms may start within 4 to 6 days after your exposure to the virus. RSV can lead to exacerbations of serious conditions, including asthma, chronic obstructive pulmonary disease, and heart failure. And evidence indicates that people 75 or older and adults that are between 50 and 74 years with risk factors are at increased risk for severe RSV. So with severe RSV, complications can include pneumonia, heart failure, myocardial infarction, bacterial superinfection, hospitalizations, and mortality. So this slide is very, very busy, but it lists like the risk factors for severe RSV, and I wanted to put them all in here so you can see that there are many. And the main thing to get from this slide is that your risk for severe RSV increases when you have chronic diseases. So things like heart failure, COPD, asthma, diabetes, end-stage renal disease, stroke, chronic liver disease, as well as things like obesity. So people who have a BMI greater than 40, people who are immunocompromised, either from disease or from medication therapy, and people who reside in nursing homes. So it's a big list, and it influences a number of people that you may see in home care for sure. RSV testing. So nucleic acid amplification tests, otherwise known as NATs, and these are your PCR tests, are highly sensitive and can be used to diagnose RSV. NATs are the most sensitive, and they're especially important for testing older adults who tend to have lower viral titers and respiratory secretions. So you need that sensitive test to find it. Antigen tests are also available, and they are generally less sensitive and more effective for infants and young children. In addition, like if you go to urgent care, you may get one test that tests all three. It tests COVID, influenza, and RSV, all in one test. And these are usually highly sensitive and specific NATs. RSV treatment for adults is supportive care to relieve symptoms. So usually we try to manage pain and fever with over-the-counter medications like acetaminophen or Tylenol or ibuprofen, brand name. One of them is like Motrin. We tell patients to drink plenty of fluids to prevent dehydration, which may worsen some underlying chronic diseases. And the use of nasal sprays or humidifiers for congestion can be helpful. So when do you seek medical attention? So as home care people, you may go in to someone's home who has RSV and to be alert to the warning signs where you should bring them to next level of care. And these would be difficulty breathing with short, shallow, or fast breathing. If someone has behavioral changes like extreme irritability, lethargy, or inactivity, and color changes to their skin, bluish or grayish skin, lips, or fingernails. And this is an immediate warning signs for medical attention. The RSV, the CDC on here, or the Centers for Disease Control and Prevention, that's what CDC stands for. They have immunization recommendations for RSV, and I put up here for the older adults. So everyone 75 years of age and older should receive an RSV vaccination if they haven't previously been vaccinated. You know, in home care, you could advocate for vaccinations if people don't have it done. And in people who are 50 to 74 years of age with certain medical conditions, the ones we showed on the previous slide, or other risk factors, they should also be immunized for RSV. Now, RSV is a single dose. It is not an annual vaccine. So all you need is one RSV vaccine at this time. And the best time to vaccinate is usually late summer, early fall to catch those peaks we saw on the initial graphs, right? So you want to have your vaccine before that starts to happen. The RSV vaccines may be administered with other adult vaccines. So if people don't want to go and just do that one by itself, you can group them together. And there are currently 3 vaccines available for adults. And these are Arexvy, mResvia, and Abrysvo that you see at the bottom. Now, what do RSV vaccines do for you? They are effective in preventing RSV-associated ED visits and hospitalizations in adults 60 years and older. So they'll prevent, the vaccine helps to decrease your chances of going into an emergency department or being hospitalized with RSV. Okay, so now we're going to look at some of these vaccines. So there are 3 that I mentioned. And at the top, it shows you some of the side effects of these vaccines, which are minimal. And then there's a warning for Guillain-Barré, which is a syndrome where people have, you start off with like leg weakness, and then it can progress to upper body and arm weakness. And that usually occurs 42 days following administration of the vaccine, but not that common and not a reason to not get the vaccine. So there are 3, Arexvy, mResvia, and Abrysvo. In the second column, you can see the type of vaccine they are. So Arexvy and Abrysvo are like the influenza vaccine we're all used to. It's an inactivated piece of the virus in that vaccine that then makes your body respond to it and mount a response. So when you get exposed to the actual virus, your body quickly destroys it. mResvia is an mRNA vaccine, like some of the COVID vaccines. And what the mRNA vaccines do is they have your body produce like a spike protein from one of these viruses. So in this instance, RSV. And then your body, again, responds to it and is ready to attack it when it's presented to your body. So they're made by 3 different companies. The dose, these are all intramuscular injections. And contraindications are to the right, which aren't that many, just severe anaphylaxis to the vaccine or any component of it. Okay, now let's move on to COVID-19. So one of the things I wanted to make sure we pointed out first is COVID-19 is the disease, and SARS-CoV-2 is the actual RNA virus. COVID has established itself as a year-round respiratory pathogen / disease. And the thing about COVID is that there's an evolution of viral variants. So new variants are expected to continue to emerge. Some will emerge and then disappear, while others will continue to spread and replace previous variants. So there's always a mix of variants that the CDC posts on their website. And now the most common variants are Omicron variety. And the Omicron variant has been found to be like 50 to 70% more transmissible than some of the earlier COVID variants. So right now out there, the most common variants are what they call XFG and NBI. So these variants change all the time. If you go to the CDC website, you'll see them changing monthly almost. So it continues to evolve, this the COVID virus. So how is it transmitted? So COVID-19 infection occurs when an infected person breathes out droplets and small particles that contain the virus. And then other people can breathe in the droplets, or the droplets can land on someone's eyes, nose, or mouth, and now you're infected. The virus can live on common surfaces, and the time that it can survive varies by the type of surface. And the amount of virus also varies, so you may or may not get infected. And the third bullet is the most important, that anyone infected with the SARS-CoV virus can spread it, even if you don't have symptoms, which we probably all remember from the COVID days. So the Centers for Disease Control have several prevention strategies for COVID. And number one is to stay up to date with recommended immunizations. Second, and I think really important for your group with the home care setting, is to practice good hand hygiene and frequent cleaning of commonly touched surfaces, like countertops, handrails, and doorknobs. People should make sure you learn and use proper hand hygiene technique, and it may be with soap and water or a hand sanitizer with at least 60% alcohol. Wearing a mask is an additional strategy and can lower your risk of respiratory virus transmission or getting and inhaling the virus. So different masks offer different levels of protection, and we've all heard about the N95 masks, which are considered the most effective. And other high quality masks include the KN95 or the KF94. And masks are determined for their effectiveness based on their fit, their filtration, and their comfort. COVID-19 clinical symptoms. So symptoms can appear anywhere from 2 to 14 days. So it's a pretty long stretch after exposure to that virus. And the symptoms may start as mild, and then some people may progress to more severe symptoms. And these include fever or chills, cough, shortness of breath, congestion or runny nose. With COVID, one of the big unique symptoms is new loss of taste or smell, fatigue, body aches, headaches, nausea, vomiting, and diarrhea. And just like RSV, there's warning signs for COVID where you should go to next level care, seek emergency care. And this is if you have persistent pain or pressure in your chest, new confusion or inability to wake or stay awake. And depending on your skin tone, you may see lips, nail beds, and skin that appear pale, gray, or blue. So that's the time for sure to seek emergency care. Some people, including those with minor or no symptoms, may develop post-COVID conditions. People call it long COVID. So long COVID has a wide variety of symptoms that can range from mild to severe, and they mimic many other common disorders or disease illnesses. So some include like brain fog, tiredness, fatigue, sleep issues, digestive problems like constipation, stomach pain, and headaches. COVID-19 risk factors. Number one is older age, especially those greater than 65 with comorbidities. They are far more likely to develop infection and have more severe symptoms. And a matter of fact, 81% of deaths with COVID-19 are among those greater than 65. And the risk for severe illness increases as your number of underlying conditions increases. So if you have a whole bunch of chronic diseases, all those kind of increase your chances for severe disease. And here are the conditions that may increase your risk for severe disease include cancer, CKD, stroke, chronic lung disease, dementia, diabetes, heart conditions, anyone who's immunocompromised, people who are overweight and obesity, physical inactivity, and interestingly, smoking. Current or former smokers are at increased risk. People with substance use disorders are also on this list. And in terms of obesity, the risk of severe illness with COVID-19 increases sharply with higher BMI. So as the BMI goes up, your increase for severe disease also rises. So what about COVID testing? The most sensitive tests are the NATs again, the nucleic acid amplification test. They're more likely to detect the virus than the antigen test, and they are considered the gold standard. They may take up to 3 days to receive the results, but there are new point of care NATs that can provide the results more quickly. Antigen tests are the rapid tests that produce results in 15 to 30 minutes. So these are the things you buy at Walgreens, CVS. Antigen tests are less likely to detect the virus than the NATs when symptoms are not present. And this is where the third bullet comes in, and it's very important. The FDA recommends 2 negative antigen tests for individuals with symptoms or 3 tests for those without symptoms. And you have to perform these tests 48 hours apart. A single antigen test, a single negative antigen test does not rule out infection. So that's a really important thing to remember. You're not just using one of those antigen tests, you're going to use several of them, depending upon whether or not you have symptoms. Okay, so how do we treat COVID-19? The Infectious Disease Society of America, or IDS-A, has guidelines on the treatment and management of COVID, and they divide it into ambulatory patients and then hospitalized patients. Today, we're going to focus on the treatment of ambulatory patients. So during the early phases of infection, the viral load is high, and your host, yourself, your immune response hasn't really mounted fully yet. Okay, so that's in the beginning of the infection. So these antiviral treatments, what they're targeting is to get rid of viral replication. So they are more effective right early on when the viral load is just increasing. So therefore, timely initiation of antiviral therapies is critical because they're more effective when given within 5 to 7 days of symptom onset. So you start the symptom onset, it's a good time to go and see someone, make sure you can get that treatment if needed. Seek medical care. All right, so here's the algorithm that the IDSA came up with to treat moderate ambulatory COVID-19 infection. So if you look at the very top in the blue bar, it says symptomatic, mild to moderate COVID and onset within 5 to 7 days, which is what we just talked about. Next, in the yellow, you assess the patient risk assessment. So is the patient without risk for progression to severe disease? Do they have an increased risk, but not high? That's the middle part with like the yellow boxes. Or are they high risk? And you see here, I don't know if you can see my cursor moving, probably not. Can you see my cursor? You can see the high risk with several risk factors. And this is where you see these green boxes. So you assess the patient risk, and you can figure that out by looking at the bottom here, where you have examples of increased but not high risk, and then examples of high risk. Then you move on to treatment considerations. And here there's a series of yes, no answers that move you through the treatments. So there are 3 drugs used to treat ambulatory COVID-19 infection. One is nirmatrelvir ritonavir, also known as Paxlovid, that you see on the commercials. So Paxlovid, you would use if you're at high risk, or it's suggested for those that have increased but not high risk. And that's this row right here. So Paxlovid. If you have drug interactions that prevent you from using Paxlovid, then you may need to use the intravenous medication. And this is the remdesivir, which is Veklury. And if you have a lot of risk factors, you probably should receive this product. If you have some, but not too high, it's a suggestion depending again on your provider, what they're comfortable with. And then the third option is molnupiravir or Lagevrio. And this one it's suggested for high risk, and then it's pretty much against here. So molnupiravir is not as effective as the others and has more side effects. So that's why it's kind of down here at the bottom. Now, if you're a person without risk for severe disease, you can see against, and against here. So you probably would not receive a COVID antiviral treatment. It's really only if you're one of the high-risk people that you should, based on what your provider thinks, receive the therapy. Now, the other thing they put in this algorithm is in the gray boxes, you can see dosing for each of the products and also adjustment for renal dysfunction. Now, what about the 2025-26 COVID vaccination guidance? The CDC recommends the COVID vaccine for people age 6 and older based on individual decision-making, also known as shared clinical decision-making. So this is a conversation with you and your provider. The vaccine and the number of doses are based on your age and your vaccination history. People can self-attest to factors that may increase their risk for severe COVID and receive the COVID vaccine. There's a modified vaccination schedule for people who are moderately or severely immunocompromised. So on this page, and I provided the link here, but there's a whole vaccination guidance from the CDC for 25-26. This one, if you look at the very top left, is for people 65 years or older. So if you go to the website, you can see the same recommendations for the different age groups and a whole different chart for people who are immunocompromised. But I just focused now on people 65 and older. And in the table, you can see there's one section that says unvaccinated and another section that says previously vaccinated. So for both of these, the number of doses for 25-26 is 2. And in the final column, they tell you about the interval between those 2 doses for people who are unvaccinated and those who had received previous vaccinations. So it's 2 vaccines for people age 65 and older spread out over the year. Okay, COVID vaccine side effects and warnings. Side effects are at the top. You can see the risks listed there. And warnings include myocarditis and pericarditis, although that seems to be more common and likely in younger men, but it does occur in all age groups. So that's something your doctor would talk to you about. And then there are the 4 COVID vaccines in the table. So there's Spikevax, Spikevax, Comirnaty, and Nuvavax, Oxford. Always pronounce that one wrong. But the type of vaccine is there. 3 of them are mRNA vaccines, and one of them, at the Novavax vaccine, is the protein subunit. So it's an inactivated piece of the virus that is in the vaccine. So 3 mRNA and 1 that is not mRNA. The route is intramuscular injection that you see in the 4th column. So if you had to buy these vaccines, like at Walgreens, etc., Walmart, they range from like $80 to $150 for each one. But many of your insurance policies cover them. So now let's go on to influenza. Influenza's causes and spread. Influenza is caused by infection of the respiratory tree with the influenza RNA virus. And they're classified into 4 types, A, B, C, and D. Influenza A and B are the ones that cause illness in humans and the seasonal epidemics that we see right in the fall and the winter. Seasonal influenza activity overall remains high nationally, like I showed you in the chart. And influenza A is decreasing while B is increasing. And these trends vary by region. And that map I showed you, it changes weekly. So if you go to the website, you'll see that map changing color almost every week. Influenza A, also known as H3N2 viruses, are the most frequently reported influenza virus this season. And among the H3N2 viruses collected since September of 25, 92% of them belong to what they call this year the subclade K. So that's a particular type of H3N2 virus. And why it's important is it's a newly emerged variant, and it's mutated, and as a result, it's spreading more easily and leading to higher test positivity rates and increased inpatient hospitalizations. So that's what's happening this year with the subclade. You've probably heard about it on the news, the subclade K. Now, one of the main things about this subclade A, they say that watch for a very abrupt onset of fever. And how the doctors have described it is you can remember the exact moment you started to feel the fever. And this is in contrast to what we usually see with influenza and RSV and COVID. Influenza transmission, viruses are spread from person to person through respiratory droplets. Again, coughing and sneezing. And transmission generally occurs via large droplets requiring close proximity. But airborne transmission can occur in confined spaces. Transmission can also occur when a person touches their eyes or face after touching a contaminated surface. Incubation time is a little bit shorter than what we saw with the COVID, but sort of similar to RSV. and usually 1 to 4 days after exposure. And shedding of virus can occur from the day before symptom onset to 5 to 7 days after. Once again, asymptomatic people can still shed influenza virus and infect others. And interestingly, infectiveness is greatest within 3 to 4 days after illness onset, and it's also higher in those that have a fever. Clinical symptoms. Influenza is characterized by abrupt onset of body level and upper respiratory tract signs and symptoms. Fever, chills, headache, malaise, non-productive cough, sore throat, and rhinitis. Many people, especially those that are older or immunocompromised, do not present with fever. It doesn't mean they're not sick. They just don't mount that well of a response. Uncomplicated influenza signs and symptoms can resolve after 3 to 7 days for the majority of people. Although cough, that dreaded cough, and the malaise can last for more than 2 weeks. And that's what makes influenza so awful, and especially in older people and those with chronic lung disease. Influenza can result in dehydration and exacerbation of underlying diseases as well. Now, you can get pneumonia from influenza. You can get primary influenza viral pneumonia, but you can also get secondary invasive bacterial pneumonia as a result of your influenza infection. And this can lead to acute lung injury, respiratory failure, sepsis, and multi-organ failure. So some of these invasive bacterial infections include strep pneumonia, Staphylococcus aureus, methicillin-resistant Staph aureus, or group A strep. So you could have an influenza infection and then a follow-up secondary invasive bacterial infection. So risk factors for complications include anyone who's equal to or greater than 65 years of age and people with certain medical conditions, including asthma, body mass index, again, greater than 40, cancer, chronic lung disease, kidney disease, liver disorders, and stroke. That's just some of them, but they're all listed on the slide here. Influenza testing. So influenza testing can inform clinical management. So, as to whether or not to initiate antiviral treatment or to implement infection prevention and control measures. Testing includes rapid molecular tests like the PCRs, as well as the antigen detection tests. The IDSA, or the Infectious Disease Society of America, recommends the use of the rapid molecular assays, or the NAT PCR tests, over the rapid diagnostic tests in outpatients. Okay, influenza vaccines. There are many, or several of them. So I have two slides on the influenza vaccines. So we'll start at the top here. The risks for the vaccines include pain, redness, etc. Warnings is caution and history of Guillain-Barré within 6 weeks after a previous dose of influenza. So if you had Guillain-Barré syndrome, which you definitely know you have, because it's symptoms include like tingling or weakness in your legs and then spreads to your upper body and your arms. So you would know if you had Guillain-Barré. So if you're a person that had Guillain-Barré within 6 weeks from a previous influenza, that's a warning. And that's a discussion with your medical provider. It's the preferred vaccines in people 65 or older include the Fluzone high dose, which is at the bottom of this table here under Fluzone high dose 65 plus, Fluad, and then Flublock. Flublock is just above. So when you look at these on this table, 1, 2, 3, 4 vaccines, they're all inactivated influenza vaccines. And they're made by different companies. And the dose is always intramuscular injection of a single dose. So Afluria, Flucelvax, Flublock, and then the next page shows 4 more vaccines. Fluad is the other preferred for people 65 and older. Now, the one kind of unique influenza vaccine is the flu mist. And most important, this is only for people 2 to 49 years of age. And this is a live influenza vaccine. The others are inactivated. And it's also given intranasally. So this is not for use in older people, pregnant individuals, children or adolescents that are receiving aspirin therapy or aspirin-containing therapy. So that's the only one that kind of has many restrictions and contraindications. Well, let's see. So the CDC recommends that everyone have an annual flu vaccine, or everyone, pardon me, people 6 months and older during the flu vaccine. So if you're 6 months and older, you should get a flu vaccine annually. To prevent some of the issues that, we talked about earlier with influenza. Okay, influenza treatment. So influenza, there are antiviral medications that can lessen your symptoms and shorten the duration of illness. Antiviral medications work best for influenza when they're started really short. I don't know if you remember COVID, it was like 5 to 7 days from onset. Here, we're talking 1 to 2 days after influenza symptoms begin. So the CDC, as a result, kind of recommends prompt treatment for people who have influenza or suspected influenza and are at an increased risk of serious complications. So some physicians, they know you're at high risk, they know you were exposed, they may not wait for your positive test and just start your antiviral medications right away. And there are 4 FDA-approved antiviral drugs for treating influenza. The first and probably most common is oseltamivir, or what you call a Tamiflu. Probably everyone's heard as Tamiflu. And this one is a tablet you take twice a day for 5 days. And the thing about these antivirals for influenza is there's a treatment for the infection, and then there's also prophylaxis for people who are close contact with you, or in a nursing home or another confined setting. So oseltamivir, Tamiflu is one. The next one is zanamivir, and this one is Relenza. This one is given by inhalation, and it's not recommended for people who have asthma or COPD. And people would use the zanamivir for, again, 5 days, and then also for prophylaxis. Paramivir, or Rapivab, which is a third down here in the list, that one is one single IV dose given by your healthcare professional. And the last one, baloxavir, or Xofluza, you've probably heard of, is a single oral dose suspension. And the unusual thing about this one is that you need to avoid co-administration with dairy products, or it'll prevent the absorption of your Xofluza. So what are some calcium-containing products that you need to avoid? These are dairy products, calcium-fortified beverages like calcium-fortified orange juice, laxatives and acids, and your oral supplements, calcium, iron, magnesium, and zinc. So you have to be careful with that. So it's a good thing when you're getting these filled to talk with your pharmacist about the dosing and the administration of the products. Okay, so 4 of those, again, they can be used for treatment and or prophylaxis. Okay, so the other thing about some of these antiviral medications is they require alteration in dosing if someone has renal impairment. So remember, we're going to be using these in people who are at risk for severe infection and they have multiple chronic diseases. So with Tamiflu, you have to modify the dose if the person has change in their renal function. So in this table on the left shows your renal function. In the middle is the changes in dosing based on your renal function. And in the right is the prophylaxis regimen modification. So this is important. If you're caring for a patient that, is in the home setting, has modified renal function, so you might want to just take a look at their prescription and make sure it's appropriate and based on their renal function. So you have to modify Tamiflu or oseltamivir, and you also have to modify the paramivir, which is Rapivab. But remember, that's the one that's given by IV, so it's your healthcare professional will make that modification. All right, so what I wanted to put here, this is a CDC brochure, and it's information you can see at the top, treating influenza or flu. Information for people at high risk for serious flu complications. And it's a 2-page flyer. It's kind of nice because it has information on the benefits of antiviral drugs, antiviral drug side effects, and probably one of the more important things, why am I at greater risk of serious flu? So if you're working with someone in home care and they're asking, well, why me? Like, why me? Why do I have to use these drugs? You could download this form and talk to them about it. Kind of like that picture shows there. Very nice. So this is from the CDC, and I have it in my slide deck, and you can find it fairly easy. Okay, so our last section is on sporadic avian influenza A, and it's called H5N1. Now remember, the other was H3N2. So this is H5, so different than your seasonal influenza. So H5N1, or avian influenza A, is a virus infection in people, has been reported worldwide since 1997. It's also called the bird flu and has caused outbreaks in US poultry and dairy cows. The primary reservoir is wild birds, but influenza A is also common in domestic poultry and swine populations. Human infections with H5N1 have occurred since 2022, primarily due to direct or close exposure to infected poultry or dairy cows. People with this close or prolonged contact are at the greatest risk of infection. Risk to the general public is low. So remember, this novel influenza virus is different from your seasonal virus that we already went through and talked about. Okay, so completely different. This is an interesting CDC website. It kind of keeps track of CDC influenza A, H5N1, or the bird flu human cases in the US. So the data this is since 2024. So if you look in the upper left, person-to-person spread, there is no known person-to-person spread at this time. To the right, current public health risk is considered low. Cases in the US since 2024 are 71, and 2 of these have resulted in death. So how does the H5N1 avian influenza spread? And there are a couple ways. Through direct contact with infected or dead birds and other animals, from contact with virus-contaminated environments, and by breathing in the avian influenza virus through the air. Very rare and limited person-to-person spread has occurred in other countries. Not here, but in other countries. So there's a nice picture on the CDC website that shows, like, a lot of people now have the poultry or chickens like in their backyard. And they show a nice picture of someone holding a chicken, right? That's one thing, direct contact with infected birds. And they show someone cleaning the chicken coop. There's your other exposure as you're cleaning that contaminated environment. And then they show the virus in the air. So either the chicken coughs, or the chicken moves its head or moves its feet, and then it's spreading through the air. So those are some of the ways. So you should avoid contact with sick or dead wild birds. I know it sounds funny, but poultry, dairy cows, geese. I think Peter showed me how in New Jersey, there's a number of Canadian geese now that have been infected with this H5N1. So don't go picking up dead Canadian geese. I know it sounds funny, but people do it. And also, do not touch or consume raw milk or raw milk products, because these, that's another way you can spread this and get this H5N1. Now, a really important thing to know is that the seasonal flu vaccine that we talked about, all those 8 different vaccines, are not designed to protect against H5N1. Those vaccines do not cover H5N1 and the bird flu. So how is it different? The signs and symptoms of bird flu can range from mild to moderate to severe. So when you look at the mild symptoms, one that's unique to this infection is eye redness and irritation or conjunctivitis. And there are pictures in the literature of people with, like, just, instead of your eye whites being white, they are beet red. Okay, so that's one of the unique signs and symptoms of bird flu. Otherwise, you have mild fever, cough, sore throat, runny, stuffy nose, muscle or body aches. And we've seen this list before, right? So it's very similar to the others. Only one that's different is that eye redness and irritation. Now, in moderate to severe infection, you may see high fever, shortness of breath or difficulty breathing, altered consciousness, and seizures. So with some of the more severe illness. Predominant symptom in US cases has been the eye redness, and less common, diarrhea, nausea, or vomiting. Complications of H5N1 include pneumonia, respiratory failure, acute respiratory distress syndrome, kidney injury, multi-organ failure, sepsis, and also inflammation of the brain, or meningoencephalitis, so inflammation of the brain. And that's what goes along then where you see seizures, right, and altered consciousness. So those are the complications. So how does it spread in its transmission? The time from exposure and infection to symptoms is 2 to 7 days. And the eye symptoms that I talked about can occur in 1 to 2 days after exposure and infection. The CDC reports that patients are most contagious during the first few days of the illness. And people with severe disease requiring hospitalization may be contagious for several weeks. The duration of illness, like influenza, is about a few days to 2 weeks. And people who are severely ill may be sick for several days. And again, we see it again here. People who do not have symptoms can still be contagious. All right, so we went through a little whirlwind there, and now I'm just going to do like a quick review of the 3 biggies, which are COVID-19, RSV, and influenza. You can see it on the left. So in the middle, the next column, transmission, how COVID spreads through infection. COVID infection when a person breathes out droplets or viruses that can then be breathed in by others or land on others' eyes, nose, or mouth, sometimes on contaminated surfaces. Symptoms to the right for COVID, you can see the symptoms that we talked about, including the altered smell or taste. And the red ones are the ones that are in common with the others. So you can see it's kind of like a big hodgepodge. Some of these symptoms can occur with all 3 of these infections. The time from exposure to infection with COVID is 2 to 14 days. RSV, again, contact with droplets from the nose or throat of infected persons, can also spread through dried respiratory secretions, and RSV may remain on hard surfaces. And the symptoms from RSV, cough, fever, runny nose, fatigue, and the time from exposure is anywhere from 4 to 6 days for RSV, time from exposure to infection. Influenza on the bottom, mainly droplets from people with flu, sneeze, or talk may land on the nose or mouths of nearby people. Less often by touching infected surfaces and then touching your eyes, nose, and mouth. Symptoms, again, are similar to the other 2 viral infections, and the time from exposure to infection, 1 to 4 days. Now, what about treatment for these common viral infections? A quick review again. COVID-19. There is antiviral treatment available, right? There's algorithms for outpatient use and moderate or severe inpatient use. So treatment includes supportive therapy and those antiviral drugs, again, if you have like the risk factors. And those include Paxlovid, remdesivir, or Veklury, or molnupiravir, or Lagevrio. RSV, there is no antiviral treatment available. It's supportive treatment only. Influenza, we have antiviral treatment. We have several products. So here you can undergo supportive treatment and also use antiviral drugs like Tamiflu or Xofluza. Now, one thing I just realized I forgot to mention was the avian or the H5N1 bird flu. Can we treat that? Now, remember, it's a kind of influenza, but it's different from the other. So we do use Tamiflu or oseltamivir to treat that bird flu. There are no nice controlled trials like you see with these other infections and antiviral drugs. So it's really case studies or retrospective reviews. But most often it's treated, the bird flu with oseltamivir or Tamiflu. And sometimes combinations of those antivirals have been used for the bird flu. Now, the one scary thing about the bird flu and treatment is there are reports of resistance of that H5N1 to the antivirals, like Tamiflu. And what we see or how that presents clinically is we give people the oseltamivir and their symptoms worsen. And even in prophylaxis, we give it for prophylaxis, and the patients get the infection anyway. So those are signs of resistance, and that is an issue. So that will be continuously monitored. Because remember, that avian flu, we have no vaccine, right? You don't have a vaccine. And now with the antivirals, resistance is showing up like across the world and in the US. So not so good. So the moral of the story, don't touch those dead birds. If you're out there with your own poultry, please be very careful, like in caring for them and encountering them. All right, so today we talked about various viral infections and respiratory viral infections, so a very limited group of infections. So what's next in this webinar series? So now we're going to take it from infection. We know these are very contagious. We know they spread through droplets and breathing out and sneezing and touching contaminated surfaces. So the next thing we want to do is talk about infection prevention and control. So how are we going to optimize our infection prevention policies and how we treat, just how we do this in the home care setting to prevent spread of these infections and others. So as Peter mentioned originally, we have a couple of additional webinars in the series. March 20th, we're going to dive into that outbreak planning and protocols for infection prevention and control. April 30th, we're going to look at best practices or interventions in infection prevention and control. On May the 29th, we're going to look at engaging patients, families, household members, and informal caregivers in this infection prevention and control grouping or work. So now we have to bring in like everyone in that May 29th. We'll try to address that. And then June 23rd, the best practices for communication, collaboration, and coordination among home care and community-based services to address some of these novel outbreaks. So including, respiratory tract infections that we talked about today, but then there are so many other bacterial infections that we also have to think about, like C. difficile or drug-resistant bacterial infections. So there's a lot for us to talk about. And I think at that point now, we're ready to turn it on to questions. I'm not sure if there's anything in chat, and I'm really close to the end, 157. I'm sorry.
You are. I have to say, Dr. Lubowski, I said to Terry, how are you going to cover all of this? It's a 1 hour webinar. And I have to say, not only did you cover it, but you covered it both thoroughly and in a manner that was really very easy to hear and to take in. Very accessible and meaningful information. So thank you very much, Terry,
Thank
for that. We do have only 1 or 2 minutes. Were a couple of questions in the chat, one in particular that was looking at guidance around quarantine recommendations and the like in a group home setting. I want to say though, and Terry, you can feel free to respond, but I do want to re-emphasize and encourage folks to come to the subsequent seminars because we'll really be drilling down around best practices for all home and community-based environments and to really inform our practice in this critical area. So thank you, Terry. But we do have 2 minutes, so I will stop. And are there any particular questions, Kiernan, that you wanted to curate and serve up to Terry?
I don't have any particular. Let me just take one quick look. I think something did come into the chat, but
I
it
would
was
like to
just
reflect on what you
lots
just
of
said.
great comments. Go
Well,
ahead, Terry.
I'd like to reflect on what you just said, Peter, about the group home setting. That we definitely have to dive into. Because remember when we talked about like influenza treatment, or I talked about that? where there's treatment and then there's prophylaxis, right? So in that setting in particular, right, you need to have prophylaxis for the other people that are in the home setting. So yeah, a lot of these infections are going to require a look at and considerations of everyone within there, within that setting. So that's a really good question. I actually made a note of it to make sure that we cover it in the subsequent webinars. Thanks for bringing it up. Definitely important.
Absolutely. Well,
Mhm.
it doesn't look like there's any other questions in the chat. If people have further questions, hopefully we'll see them in our next webinar. And I thank you all very much. I'm going to go ahead and stop the recording if there is no more questions. And everyone have a
Please,
great day.
please do complete the evaluation